Hello, and welcome to today's Center for Healthcare Strategies webinar, made possible through the support of the Pew Charitable Trusts. Today, our topic is Contingency Management Programs, State Lessons from Planning to Scaling. My name is Carla Silverman, and I'm Associate Director, Women's Health and Clinical Innovation at CHCS. On the next slide, we're going to go through some logistics. To eliminate background noise, audio lines are being muted during today's event. However, we really want to hear from you. There will be a Q&A session towards the end of the webinar, and we encourage you to submit a question at any time by clicking the Q&A located at the bottom of your screen. Also, today's event is being recorded and will be posted to the event page on chcs.org in the coming days. Materials will also be emailed to all registrants. On the next few slides, I'll review our agenda for today and introduce our speakers. Next slide, please. Thank you. Today's webinar focuses on contingency management as a strategy to address substance use disorders, with a particular emphasis on state implementation lessons. We'll start with an expert overview of CM, what it is, why it works, and insights from recent research on how states across the country are putting CM programs into practice. After that, we'll hear directly from state officials who are going to share their on-the-ground experiences designing, launching, and managing CM initiatives. Following presentations from our speakers, we'll have time to respond to your questions. Thank you for sharing them with us as you registered and throughout today's session. Our goal today is for everyone here, and we know many of you are joining us from state agencies, to come away with insights, strategies, and inspiration, no matter where your state is in planning or implementing contingency management to address substance use disorders. If you're wondering whether this work is truly possible, we hope you leave knowing that it is. And if you're already implementing but facing real challenges, we hope the examples and lessons shared today offer clarity, motivation, and practical guidance to help keep you moving forward. Before I introduce and turn it over to the presenters, I want to share some information on the Center for Healthcare Strategies. Next slide, please. Center for Healthcare Strategies, or CHCS, is a policy design and implementation partner devoted to improving outcomes for people enrolled in Medicaid. CHCS has worked with states, managed care plans, healthcare providers, and community-based organizations across the country to increase access to services and support the growth and sustainability of this Medicaid workforce. Thank you. Next slide. Now I'll introduce today's presenters. First, we'll have Dr. Michelle Peavy, Scholarly Associate Professor, Elson S. Floyd College of Medicine at Washington State University, and co-director of the Northwest Rural Opioid Technical Assistance Collaborative. Dan Bizjak, Substance Use Services Section Manager, Bureau of Prevention, Treatment, and Recovery, Division of Care and Treatment Services at the Wisconsin Department of Health Services. Chris Scalise, Manager of Special Initiatives, the Women and Families Unit at the Office of Treatment and Recovery Supports, Division of Mental Health and Addiction Services at the New Jersey Department of Human Services. Tevis Thompson, Contingency Management Project Manager at the Division of Mental Health and Addiction Services at New Jersey Department of Human Services. And Dr. Sherry Nichol, Behavioral Health Medical Director, Division of Substance Abuse and Mental Health, Delaware Division of Medicaid and Medical Assistance. Okay, so I would like to turn this over to Michelle. Next slide, please.
Thank you so much for the invitation, and thank you for all of you out there interested in helping people with substance use disorders. Next slide. I have no disclosures in next slide. So I'll be talking a little bit about contingency management as an intervention, kind of defining it, and then talking about two examples of statewide rollouts of the contingency management intervention, one in my home state of Washington and the other in California. It's called the Recovery Incentives Program. And just by way of background, I am a part of a team that provides training and technical assistance for these CM statewide rollouts. I'm trained as a clinician and spent most of my career in direct service of people with substance use disorders. So next slide. First, a little definition of contingency management. What is CM? Sometimes it's nice to have a one-liner. Well, contingency management, it's a behavioral therapy that uses positive reinforcement to encourage change. And in this context, CM, of course, defines positive reinforcement as typically tangible reinforcers like gift cards. But I also want to say that the positive reinforcement is so much bigger than that. So if anybody out there has done CM, you already know this, and that the sort of like whole ball of wax with the positive reinforcement is with celebration and people feeling good about the changes that they're making, as well as the interaction between the person delivering CM and the person receiving it. So that's the positive reinforcement part. Now, the change part with contingency management, that depends a little on what the CM is focused on. And in today's example, we're talking about change in the context of reductions in stimulant use. So stimulants, drugs like methamphetamine and cocaine. And that could be slowing down stimulant use, cessation of stimulant use, taking a break, etc. And I also just want to say, of course, it's not just that we use CM to suppress stimulant use. People don't just want to stop using drugs. They want to change their lives and improve their lives. So that's what CM is really about. And again, it's sometimes good to have a definition. Go ahead and go to the next slide. There are so many myths and misunderstandings about contingency management. This has been my experience doing CM and also doing training in this space. And I address some of just a few of the many misunderstandings here on the slide. I won't go into detail on all of them, but I do want to draw our attention to that last row, which says that CM is not paying people to not use drugs. And using this kind of language is a real mischaracterization of the intervention itself. So I want to really discourage this language. Again, CM is a behavioral intervention, and it's one based on what we know from behavioral principles about what helps people change. And at its best, contingency management builds confidence, enhances morale, improves therapeutic relationships, creates opportunities to celebrate. And yes, it does help people reduce stimulant use if that's what they so choose. But when we say that we're paying, quote, paying people to not use, again, a complete mischaracterization, that leads people to believe that people will change, do the hard, difficult road of change for things like a $10 or $20 gift card. And people don't go about doing that hard work for that. People want better lives. People want better relationships. And this is sort of what CM is really getting at. And CM might be the nudge to initiate that change. But we know that it's much broader than that. All right, so take a look at those myths later on if you want. But for now, let's go on to the next slide. And I'll just say that contingency management is really backed by research. So what you're seeing here on this slide is multiple pictures of articles that are meta-analyses spanning decades of contingency management research. And I'm not going to go into detail about the research that backs up this intervention, but just suffice it to say that across the decades, rigorous randomized controlled trials and meta-analyses have shown us that CM has some of the strongest evidence bases in all of substance use disorder treatment. Over the weekend, I was deep in CM literature for some project, and I saw an article in there from 1977. So, that's almost 50 years ago. On the next slide, there's a QR code that kind of leads you to cm.info.org and has some more link outs to research if you so choose. And I'm just going to pause here for just a second in case you want to grab that QR code. and say that one of the areas with the most robust evidence for CM is stimulant use. So CM, of course, can target a number of different behaviors like treatment attendance or medication adherence. But today we're going to really be focused on CM that focuses on reductions in stimulant use. So that research has really been around since the 1990s when CM has been tested on within hundreds of randomized controlled trials. And so that strong evidence base is really one of the major reasons why these statewide rollouts tend to focus CM on stimulant use in particular. All right, so going to the next slide. Again, that's one reason why these statewide rollouts focus on stimulant use is because of that large evidence base. And there are other reasons why stimulant use is the focus. Urgency, of course. How do we help people that have a stimulant use disorder? And CM happens to be the standard of care for stimulant use disorder. So again, that's why the focus. All right. So next slide, a word about regulation. So I'm a clinician at heart, and words about regulations aren't all that interesting to me, but I do feel the need to talk a little bit about the regulatory environment. And you yourself might have a lot of questions about this slide or questions about the regulations. And of course, I cannot provide any legal advice for you or your use of contingency management or the regulations around it. What I can say is that there is a regulatory landscape within the contingency management world, and federal anti-kickback rules, which are dictated by the Office of the Inspector General, generally prohibit incentives in the use of healthcare. However, there can be so-called safe harbors underneath which contingency management can operate. So CM is not illegal if done underneath these so-called safe harbors. So it just requires that contingency management programs are designed and executed thoughtfully. And one way to minimize risk of running afoul of the federal government's Office of Inspector General is to align contingency management protocols with those already operating under Medicaid 1115 waivers. So, and even those aligned protocols should put safeguards in place to prevent fraud, waste, and abuse. So that's all I'm going to say about regulations, and we'll go on to the next slide and talk about the contingency management rollout in my home state, Washington State. So the effort to get this evidence-based treatment out to residents of Washington has a kind of a fun story. A clinician who she was having difficulties trying to help her patients with stimulant use disorder. She's located in Spokane, Washington. Looked down the street at Washington State University and said, "Hey, there are researchers at WSU who study treatments for stimulant use disorder. Why is this not available to my patients?" And that really kicked off an effort by the Washington State Healthcare Authority in getting this evidence-based treatment available to people in Washington State. And I really have to hand it to the Washington State HCA. They've really made that a priority. So first, what they did was they took SOAR funding and they use that to fund the training and technical assistance. So I'm part of that team providing the training and technical assistance to get this intervention implemented in busy and complicated clinical sites. The money used for incentives and the urine drug tests were with other funding. So they braided this funding together and they got this program off the ground. And that while that infrastructure was building up and we were figuring out what it looked like and how it worked, that's when they explored how to get contingency management as a Medicaid funded benefit. and put forth the 1115 Medicaid demonstration waiver, which was approved in 2023. And I realize it's now 2026, but at this point now we are getting that underway. So next slide has our original sites for the that first wave. A lot of these are rural sites. And I also want to say that most of these sites are rural primary care settings. In the next wave, there'll be a lot more specialty substance use disorder settings. Next slide. This is generally our protocol, and I just want to alert you if you are a program looking to develop your own evidence-based protocol, those questions on the left-hand side are what we use to develop that protocol. So you ask yourself those questions and respond there on the other side. Okay, so the next slide has some of our numbers. We are a humble, again, we're rural serving sites. This might seem very small compared to the next slide, which are the California Recovery Incentives Program. This is a massive effort in California. On that next slide, they have served over 10,000 patients over the course of their contingency management pilot. And I'll just end with some ideas that you can consider if you yourself are considering a contingency management program. So go actually 2 slides down. And really, when we think about implementation challenges, there are certain logistical challenges that mean CM would be a no-go for your site. And then there's just the implementation challenge when people don't like it or people don't understand CM. Those are more sort of philosophical challenges, which can be overcome. So on the next slide, there are some questions again that you can ask yourself that will determine whether or not CM is really a no-go for your site. So, if you aren't an outpatient facility, if you cannot use point of care tests for whatever reason, et cetera, any no answers to these questions might mean that CM might just not be a good fit. If, however, you can go to the next slide, there are people in your organization that just don't like contingency management. This is really common or don't understand it. Well, that can be overcome with not just good discussions and conversations, but also when people get some experience with contingency management or hear from people who benefit, that's when it really helps. So thank you so much for your time. I'll hand it off to the next speaker. Really appreciate it.
Thank you so much, Dr. Peavy. Wonderful presentation. I'm going to turn it over now to Dr. Nikel from Delaware. Take it away,
Hello.
Sherry.
Happy to be here to talk to you all about Delaware's contingency management initiative. Next slide. So I will just talk a little bit about our initiative overview, some of the design decisions and why we made them, and focus on collaboration with sister agencies, which played and continues to play a large role in what we're doing in the state. Next slide. So the first thing is we named our program Recovery Incentives to Strengthen Engagement. Anyone that knows me knows I love a good acronym. They're easy to remember. So it's our RISE program. It was important for us to have something that better explained what we were doing. Shockingly, people don't always know what you're talking about when you say contingency management. We came up with a program that would support eligible Medicaid beneficiaries in Delaware, and there was 2 arms to it. One is for individuals 18 and older with a stimulant use disorder, and the second is for pregnant and parenting folks who are over 18 with an opioid use disorder. We were the first state to be approved to work with women and other individuals with a pregnant opioid use disorder. So that was kind of exciting. Our incentives, each sub-program is 24 weeks in duration for our pilot. The OUD program, when we have our statewide launch, is actually 64 weeks, so it's a little bit longer. And our pilot ran from December 2025, and it will end in June 2026. And that is because we are funding our pilot using the American Rescue Plan Act, enhanced funding for home and community-based services. So ARPA funding is what we are using for our pilot. And the state share cost of the statewide rollout is funded through the state budget. It was very exciting to see our division director talk about our contingency management program last year in our joint finance committee and be able to educate the legislature about contingency management as he sought to make sure we had the funding to continue our statewide launch. Next slide. So these were the treatment goals that we had. So the first was the obvious one, which is there is a high rate of overdose deaths involving stimulants. So we wanted to address that issue, also knowing that this is the standard treatment for substance use disorder. And the goal is to have drug tests that do not indicate stimulant use. And this would be monitored via urine drug screening. And we did a lot of work in explaining the program, but also with the 2 pilot sites to make sure they understood that the goal was to see that the urine drug screen did not indicate stimulants. It could have every other substance under the sun in it, but if it did not have stimulants, people would still get their incentive. The second arm of the program was that the high rate of opioid use by pregnant Medicaid beneficiaries. We'll talk about that in a second. And what we made our goal there was adherence to MOUD, or medication for opioid use disorder treatment, and it was monitored depending on which type, if they were on an oral or sublingual formulation, if they were on a long-acting formulation, if they were on methadone. It's each a little bit different in how we would measure for the incentive. Next slide. So I forgot one thing to say. If you could go back one slide, I'm so sorry. So our numbers don't look great. Delaware is a small state, but we've already maxed out the number of folks we had set aside for the pilot in each of the sites. One site we're very close to doing it. So we've had high uptake of our stimulant use sub-program. We have one enrollee in the PPP arm, which was not surprising to us. It's a small, very, very small population that we had. And I do know that one of the things that came up when we were talking about who could enroll in each program, it was really important in following the federal regulations that you couldn't entice someone who's in a successful treatment somewhere else. They're enrolled at, provider A, and say to them, why don't you leave provider A and come over here to provider B so that you can be in this program? You're not allowed to do that. So that was number one. Number two, we were clear around stimulant use disorder that if you had someone in your clinic who was doing very well and not using stimulants, they would not qualify for contingency management since they were already meeting the goal. Should that person start to have difficulty again in maintaining abstinence from stimulants, they could be enrolled, but it was important to be clear about that. We were less so with opioid use, right? If a person was pregnant and on our MOUD and doing okay, we could still enroll them, particularly in the statewide launch that will go out for 64 months. The idea was to get folks into the program and ensure that they would stay on their MOUD even after delivery and into the postpartum period. So in the pilot, we're anticipating and that we won't see a whole lot of women yet. We also want to make sure that we're in the process of meeting with our providers, make sure they're clear on the fact that this doesn't necessarily have to be someone who's not taking their MOUD. The goal was a little different. Okay, next slide. So we had 2 payment things that we needed to think about. One was that there would be a coordinator and a backup coordinator at each site, and that would cover time for the CM coordinator to do patient education, enter the urine drug screening results into the platform, and we were using gift cards, so they would distribute the gift cards again in real time. that will be funded through our fee-for-service program for managed care enrollees. So there will be an exception for this particular code that when it's billed, regardless of whether the client member is in a managed care organization, the fee for CM coordination would come out of the fee-for-service budget. You can see the amount that we have there. The urine drug screening, the analysis was going to stay under managed care, and that was something that we talked to them about because usually the service frequency was limited on medical necessity, and this was going to be different, asking them to do 2 screenings a week. So that was something that we negotiated into our master service agreement to leave that cost into the managed care plans. The one thing that we didn't put in here was our contingency management platform. And we'll talk a little bit more about that when we talk about our sister agencies and our overlap. But the decision was made to keep the platform under fee-for-service as well. We knew that there was there's a lot of scrutiny in these programs, given that this is a relatively new thing to fund through Medicaid, and we wanted to make sure that we had a good handle on fraud, waste, and abuse. So we are keeping the incentive platform management in fee-for-service. There's a lot of conversations about how could you hold the managed care organizations, of which we have 3. Would they be allowed to choose their own incentive platform? Would we make sure they only use the same incentive platform? There were lots of logistics that felt really difficult if we were to make it a managed care benefit entirely. So we left it out in fee-for-service, and so far for the pilot, it's been very helpful. Our managed care organizations did get involved we did training to let their care coordinators and care management folks know that this was an option. So if they came across members that could benefit, that they could point them in the direction of these programs. And we are asking them to keep track of when that happens, so it could be one of our data points as we move forward. Next slide. So this is just the approval timeline: California, Washington, Montana, and then Delaware in May of 2024. And as I said, we were the first state to include the PPP with OUD population. There was a lot of conversation that we had with CMS to help explain what it is that we were doing, and me drawing on my clinical experience in, accountability with people taking medications. They show up to pick up their prescription. Does it show up in their urine drug screening? How do you look at the metabolites, things like that we had to sort of explain, because it didn't feel as cut and dry as is there or is there not a stimulant in the urine. Next slide. So why did we decide we wanted to include the PPP population? So Delaware has the 8th highest rate of SUD among pregnant Medicaid beneficiaries, and the 3rd highest rate in the country for neonatal abstinence syndrome. And we have some other morbidity and mortality statistics that are not where we would like them to be. So there's been a big push in the state in general around working in maternal mental health, substance abuse, and this fell nicely into that window. So we're looking forward to being able to have some data about that moving forward. Next slide. So the rationale for the $599 incentive cap. So we thought that this was important. We put in that incentive cap, and we were very surprised when CMS came back to us and said that they wanted us to increase the maximum payments for each program to, as you can see, $1,100 for the STD program, and almost $3,000 in the PPP program, which we were thrilled. The reason they did that is that the data shows that that's closer to what we find most effective in these types of programs. What it did bring up was the tax reporting implications. So if the law where the cutoff was 599 and it wouldn't count as income, right? You wouldn't certainly want anyone to have this count as income. It'd be just enough money to have them lose their Medicaid benefits, for example. They came back and said that Treasury told them it was okay, but we couldn't get any written documentation of that. And then there was a change in administration. So we decided it was best, after speaking to our Deputy Attorney General, that we would stick with the 599 cap. And but recently there's been some changes in the 1099 laws and what counts as income, with the tax threshold being 2,000, and SAMHSA has guidance that is suggesting that the cap be increased to 750. And so we're working on increasing the cap to 750 for our pilot program, and then readjusting the numbers when we roll out statewide, so that we can get closer to what we know will be in line with the evidence and caps. Next slide. So collaboration with sister agency, and it should probably say agencies. So it was a really interesting, it's still going on. It's been a very interesting adventure launching a program within Medicaid. So I was talking to a colleague this morning, and we've sort of set up programs and launched them. We have a doula program that is now with the managed care organizations, and our food and diaper initiatives for the PPP population that were launched and then moved into managed care. This one was a little bit different because we are holding on to a lot of this program moving forward. So just internally, we did a lot of education with our colleagues to get them on board, because we were often asking financial or policy to do things that they weren't used to doing. So we had to get some buy-in into how important it was to launch this program. One, it was exciting because we were one of the first folks to do it, but two, shared a lot on the statistics around stimulant use disorder, the increases that we were seeing, how this was the gold standard treatment, and I'm pleased to say it was fun to see our internal DMMA people come along with us and be very excited and continue to be really supportive. When we were going through the process of contracting with our contingency incentive platform management provider, that was an adventure. So I've joked multiple times that I missed all the contract and vendor management courses in medical school, right? I skipped those. So it's been a lot of learning on my side in terms of how to figure this stuff out. But we were so happy. We've been so happy that we had the ARPA money to run a pilot before we went to the statewide launch, because we got our contract signed with our platform, and at the last minute, they told us that we were missing a key sign-off from our Department of Technology and Information. We had run it through our own internal information resources management, thought that was enough. It was not. It took us 3 months to finally get the right person who could tell us what information they needed and approved it for this online platform that we would be using. So we're hoping now, as we move forward with the statewide launch, and we had to have sign another contract for that we know what's happening. But that was tough because, again, it was outside of our control, right? So we were working with them. The other collaborations that we've had is that we've worked closely with the Division of Substance Abuse and Mental Health, because they were running, one, they know a lot of the providers. We had asked some of our managed care organizations if they had ideas on who might be good, and then we worked with DSAM on who they thought would make good providers to participate in the pilot. We also had to make sure that we were aligning our programs, because they were funding a number of contingency management programs using state opioid response grant funding. And we knew that we could not overlap. It would be important that folks were only in one program or the other. And we are continuing to have the conversations about how we can move some of the programs that are using SOAR funding over to Medicaid's for sustainability. And we wanted to make sure we had the same messaging and technical assistance that was out there, and making sure that our communications were also aligned. And that's been a wonderful partnership. We've done, there's been a lot of great crossover and sort of conversations. And again, DSAM has been very, very supportive of our launching this program, as they can see that this was incredibly going to be helpful. And I think that is my last slide.
Thank you so much, Dr. Nichol. Wonderful presentation. And now I'd like to turn it over to Dan at the Substance Use Services Section Manager at the Wisconsin Department of Health Services. And please, if you have questions, put them in the Q&A. Over to you, Dan. Thank you.
Thank you. All right. Hi, everyone. So Dan Bizek, Substance Use Services Section Manager of Wisconsin for the Department of Health Services for Wisconsin. Apologize. Next slide. So Wisconsin's a little different than some of the other states that are presenting with us today. And so Wisconsin is a home rule state. So our counties operate independently along with our 11 federally recognized tribal nations. 12, we do have one that is not federally recognized, but we do still work with all of them. So our plan for contingency management actually started with SOAR 2 when stimulant use disorder was an allowable diagnosis for which source funds could be utilized. And so since then, Wisconsin has kind of taken off with contingency management. As we go through the slides, you will start to kind of think through how Wisconsin operates, just in the sense of some of the logistics that we work within. And so one of the things that we have started to see is that each agency has kind of taken on their own identity with contingency management, along with how they are funding it. Next slide. So Wisconsin does not have an 1115 waiver. And so our funding for contingency management has come from the SOAR grant, our block grant, and then also GPR, general purpose revenue funding. One of the things that we have also started to realize is that a new trend that is happening in Wisconsin is the sustainability has occurred within the counties and tribal nations. And so there is their own either tax levy or their own sustainability has occurred. And so each county, again, as a county-led state, has their own individual funding streams for sustaining contingency management within their local geographic area. Next slide. So if Wisconsin's a county, let's say, what do we do at the state? And so the way that we do and support contingency management is a little different. So with the SOAR dollars, we actually partner with our University of Wisconsin-Milwaukee, and they provide our contingency management training. We actually provide year-round best practice and evidence-based practice trainings free of cost to Wisconsin providers. How we are doing implementation is based upon the agency. Whether this is a tribal nation, a county agency, or a private agency, however they want to operate, it is up to them to ensure that they are meeting the safeguards and that they are implementing contingency management to fidelity. DHS does implement oh my gosh, I am so sorry. So we verify the implementation of the safeguards from the SAMHSA advisory as we do our contracting oversight, or we do site visits with agencies to ensure that there is fidelity. And so one of the pieces that we always do is we try to be as flexible with providers as possible and allow them to be as independent as possible to meet the needs of their population. And so we always advise that if an agency is going to implement contingency management, they consult their own legal counsel. Again, with contingency management implementation, each tribal community, each county, each private agency or nonprofit, they all have a different barrier that they face. And so it's really hard to structure commonalities between them when each of our geographical trends is very different. So case in point is that in the northern part of our state, stimulant use disorder is a primary diagnosis. But in the southern part of our state, it's more opioids. However, what we are starting to see recently is that there's a polysubstance, right? This isn't new information for us across the nation, but because of that blending, it then changes the dynamics along with some of the different barriers, such as transportation or food deserts, things like that. Next slide. So when we come to kind of that contract oversight or the role of DHS is when we do contracts, again, we do have to work with our government project officers. So Block Grant has set the cap for incentives at $75 per person per year. However, SOAR does give the $750 per person per year. We do give the flexibilities to the provider of the cap for the SOAR grant. However, with the Block Grant, it has been verified that we do have to maintain that $75. And again, because of the implementation and those different capacities, we do always refer agencies to work with their own legal counsel to ensure that they have proper and ensure that they are meeting fidelity through policies and procedures. Again, directly out of the SAMHSA advisory, and we use those safeguards kind of as our own safeguards from a state perspective. Next slide, please. So one of the components that we do with our contracts is we always do a site visit with our agencies, whether it's virtual or in person. And so we end up asking 4 questions to, again, give the flexibility back to the provider, tribal, community, county, or entity, private agency themselves. And so these are 2 of the questions. The next slide will have the other 2 questions, but ultimately asking which model of contingency management are you using? And then are you doing it to fidelity? Next slide. These last 2 questions are also where we can step in and provide support as much as possible. So have staff completed best practice training? If they say no, then we provide them the resources. And again, if they don't have policies or procedures, we can provide them resources. Again, we partner with University of Wisconsin-Milwaukee to offer that training for free, and then also support them with the SAMHSA advisory as far as the safeguards, as far as one person needs to be kind of a champion for that process, who's ensuring a check and balance system, things like that. Because of the flexibility to providers, we really don't step into internal decisions or business decisions, but we try to do as much support and resources as possible for all of our providers across the state. Next slide. So as we've been doing contingency management probably since about 2022, when SOAR 2 was launched, we did come up across a couple different pieces that we are still kind of working through. The first one is the advancements in technology. One of the pieces that is coming up is use of debit cards as far as the support of contingency management. We do not support contingency management through debit cards. We utilize the SAMHSA advisory, which specifically states gift cards, and again, being specific to the population that they are specifically serving. That should all be outlined in their policies and procedures as far as who's receiving contingency management and what their supports are. As Delaware was talking about the tax implications, not going to go through that again, but we ran into the same issue. And then also multiple funding streams can get confusing between Block Grant and SOAR. And then if an agency is choosing to use their own sustainability, whatever those caps may be, whether they choose 75 from the Block Grant, 750. But again, those funding streams oftentimes come up with their own limitations. So that is my time. So Carla, passing it back to you.
Thank you so much, Dan. So helpful. And now I'd like to turn it over to Christine Scalise and Tevis Thompson from the New Jersey Department of Human Services.
You can go to the next slide. I just want to thank everyone for allowing New Jersey to participate on this very informative webinar. So for New Jersey, how we came about with the contingency management is we had the opportunity because of the SAMHSA's state opioid response funding. We found over the last 7 years, our treatment admissions indicated the use of stimulants has increased dramatically. and in particular in cocaine emissions, primary, secondary, or tertiary substances, along with crack, cocaine, and methamphetamines. So our division was pleased that we had the opportunity to include contingency management as a treatment opportunity. So, as all states, we have procurement rules. So, we had to issue a request for proposal to address stimulant use disorder. Even though the RFP led to the establishment of 5 programs, we actually wrote it in state fiscal year 22. And with this RFP, we were able to establish 5 pilot programs that served 6 locations. Now, even though the awards were done, it took over 6 to 7 months to ramp up the services. We also had the opportunity in 2023, state fiscal year 2023, to do a program expansion, which included 6 providers, and we're currently serving 10 locations. So our funding source is through SAMHSA's State Opioid Response. Each award is $400,000. And that included specifically initial funding that we allowed for startup costs such as computers, phones, data planning, and staff recruitment. So New Jersey's CM program addresses the use of stimulants in conjunction with other behavioral therapies. We have set eligibility requirements. You must be a New Jersey resident, 18 and above, with a stimulant use disorder within a 12-month period. And we want our individuals to have an interest in participating in the program. You can go to the next slide. So we require our providers to assess for clinical criteria, primary, secondary, or tertiary, using the DSM-5 criteria. And we've added at least 2 of the following occurrences within the 12-month period: taking more stimulants than intended, or failing to cut down or control use of stimulants despite wanting to do so, spending excessive amounts of time and activities surrounding stimulant use. Again, this was a new process, a new program for our state. So as we developed the RFP, we really we actually used SAMHSA's best practice models and how we could deliver this service. We're looking if you experience urges and cravings for stimulants, are individuals failing to meet obligations of home, school, or work? Is an individual continuing to take stimulants, even if it's leading to relationship or social problems? Are they giving up reducing important recreational, social, or work-related activities because of the stimulant use? Are they using stimulants in situations that could be physically hazardous? And are they continuing to use stimulants even if there's an awareness that it's causing or worsening a physical or psychological problem? And are they experiencing an increase in tolerance to stimulants? The interesting piece is that as all states were dealing with the opioid crisis and the risk of overdose and fentanyl, we saw such a high increase in our admissions. And again, we were happy that we could have this opportunity. You can go to the next slide. So the programmatic piece, our provider requirements are, we expect to serve a minimum of 100 clients annually. We expect the staff to meet all the professional licensing requirements, regulations, and our treatment planning has to be in compliance with our requirements. Our providers are required to comply with data collection, data submission, and all the reporting requirements, state and federal. This is a 16-week program with the $75 maximum incentive allowed per client. Unfortunately, it's not in our 1115 waiver. And when we developed the program, at that time, the incentives were not up to $750. So we have a $70 non-cash incentive with a $5 gift card that's provided at the orientation session. Our clients are compensated with an additional $25 gift card after completion of the 16-week period. And the gift card is really for completing program evaluation forms. That's not considered an incentive, but it's related to, at the time, the SAMHSA SUPTR completion. I'm sorry, I'm using acronyms. SUPTR stands for the Substance Use Prevention, Treatment, and Recovery part of funding through SAMHSA. And then we are asking our program providers to develop protocols that utilize the non-cash incentives to improve outcomes on individuals who have stimulant use disorder. I'm going to turn the slides over to our program manager for the CM program, my colleague, Tevis Thompson. Go ahead, Tevis.
Hi, thanks, Chris. So the New Jersey approach to CM is that it's an additional service to further support the treatment and recovery journey of persons with primary, secondary, or tertiary stimulant use disorder. Contingency management pilot was to be used in addition to other evidence-based practices for treatment and recovery. Contingency management does not serve as a standalone initiative. Contingency management is utilized and tailored based on each individual client's needs. New Jersey leans very hard into meeting your client where they're at. New Jersey promotes a non-punitive, supportive contingency management model in which missed benchmarks are prompted problem-solving meetings rather than a reset. So our clients don't have to go back to the beginning. They just pause where they're at, address what the issue was, and move forward. Successful benchmarks are reinforced with incentives. Next slide, please. So expansion considerations. Flexibility is key. It is the most important factor in running a successful program. Awarded providers have needed to be able to adjust changing conditions and patterns based on unique circumstances of their client population. They can offer both third-party substance use screening tools via smartphone, but several providers use Dynamic Care Health as that screening tool, as well as they also offer in-person substance screening at the provider's locations for our clients that do not have access to smartphones. Offering contingency management 2 weeks post-intake when a person arrives as a new person seeking treatment and recovery, whether it's someone coming from the inpatient setting, transitioning into outpatient setting, or coming to the outpatient setting. This allows them not to feel quite so overwhelmed by everything being thrown at them when they first come in looking for treatment and recovery or are transitioning out of the inpatient realm. Clients choose their recovery goals, whether it's full abstinence or a reduced amount of use or frequency. Second RFP that we made available to support the expansion of contingency management services. A select few first-round awardees applied for and received additional awards to implement the program at approved additional locations, including geographic expansion within the state of New Jersey. Consistent with the RFP terms, some awardees expanded their services to additional sites through contract modification using their original award without requesting or receiving additional funds. So if they were finding that the location they had been awarded to was seeing a good influx of clients, but also a secondary location that they had open was also seeing an influx of clients with stimulant use disorder, they would contact us for a contract modification. We would allow them to also offer it at another location. Next slide, please. For sustainability and scaling, in October of 2025, New Jersey combined the Contingency Management Pilot Program, which was designated as Contingency Management 1, and the second round of funding awards, which was designated as Contingency Management 2, into one program and eliminating the pilot program label. The pilot program ran for 2 years. This was now a third year where we had 2 separate programs. We converged them into one. So New Jersey's current contingency management program now stands at 10 program locations throughout the state, administered by 6 providers. New Jersey continues to focus on continuous improvement with a focus on data collection and analysis. We do have a dedicated research specialist who works very closely with me as far as gathering the numbers and making sure data collection being is being done, and that if there's any questions or concerns, that he's able to address them with the provider. Data is being used to examine potential growth as needed to strengthen and improve this program. Next slide, please. So of the lessons learned that we've had, first of all, the number one thing, most importantly, is that we allowing program flexibility within reason and focusing on building a collaborative relationship with providers. We have a standing one-on-one meeting with each of the providers. I meet with each program manager every month. Usually it's 15 to 30 minutes to address any barriers they're encountering, talk about any successes that they are having, and answering any questions or concerns that they might have. We've also instituted allowing a 30-day pause in the program if a client needs to be admitted for a higher level of care or if they become just disinvolved. The other consideration we have is providing the contingency program staff training twice annually through a contracted technical access center, Rutgers University Behavioral Health Care. And also leveraging participant word of mouth as a key engagement strategy. And also for our standalone outpatient only providers, having them be in getting cross-system referrals and collaborative partnerships to enhance access. They have built relationships with our children and family services, recovery court systems, and in the offices of parole and probation to allow those clients to have evidence-based practices that may help them with their substance use disorder, primarily stimulants. Thank you so much, and I've really been thrilled to present today.
Thank you, Tevis. Thank you, Christine, for a great presentation. And thank you to all of our presenters for really giving us an amazing window into the incredible work that's happening to promote contingency management, this evidence-based treatment for people with certain substance use disorders. So we greatly appreciate you. We're now at the question and answer portion of the session. So I invite all of the speakers from today to turn on your cameras and we'll filter through some questions that we received during registration and during today's presentation. If you have any questions, there's still time. So, please use the Q&A button at the bottom of the screen if you have any questions for Tevis and Christine or anyone who just presented. Yeah, so let's get into it. I guess, maybe starting with Michelle, and maybe also Sherry for this question. This question on where is contingency management delivered? We heard in the presentation so much it's being delivered in behavioral health outpatient settings. But I think, Michelle, in your presentation, you also mentioned primary care practices, which is so interesting. And Sherry, part of Delaware's Medicaid waiver is focused on pregnant and parenting individuals. So we had a question in the chat about, trying to engage OB/GYN providers in this work. So maybe starting with Michelle, I'll hand it to you to think about that.
Yeah, the Washington State CM rollout was really piggybacked upon the SOAR efforts. So there's a network of providers that were providing MOUD and primary care. That was part of how Washington State SOAR funding was allocated. And so the CM, then we took those sites and used the networks that they'd already created and got CM up and running in those sites. And they had all their, other networks, hubs and spokes and things. And so we were primarily in settings that are primary care settings. And there's pros and cons of putting CM in a setting like that. Most primary care settings don't see people twice weekly, which is the protocol for contingency management. There are limitations in terms of staffing and space and so forth. But if you are a primary care setting that really wants to help your people that have stimulant use disorder, you find a way to make that happen. So we have really dedicated nurse care managers and patient navigators that work in these primary care settings to get up and running. Our next cohort of sites we're bringing on right now have more of the like specialty SUD clinic, which in a lot of ways is a better fit because the infrastructure is there. The urine testing is already part of treatment. People are already coming to, IOP groups and so forth. So in a lot of ways, that's a better setting. But how do we really reach people where they are? We have another project happening in a permanent supportive housing setting. I've worked with syringe service programs, getting CM up and running. So, let's get CM to people that need it. And that might be in specialty SUD treatment. It might be in primary care. It might be in laundromats. Let's just make sure. And I say laundromats because on the California project, they do a great job of doing outreach to people that could benefit from CM. And they go to laundromats to advertise their CM program. So anyway.
Yeah, it's a great question. And I can add that for our pilot, we went with specialty SUD and behavioral health clinics for the reason that it was already sort of set up, and we wanted to make sure in the pilot that people could hit the ground running. It's also given us some time. So we know for sure of there are a couple primary care clinics who are already doing contingency management on a very, very small scale. So they have this set up for stimulant use disorder in particular. And we do a lot of work, our team, with we have a maternal health task force and several other organizations within the state, so that we're working right now to identify good OB clinics and other primary care places. Again, to the idea to meet people where they are. We sort of know that a lot of folks won't make it to us as specialty SUD provider, even if they're sent there. And so the hope that if we have a tool that can help get them there, give the providers some confidence in treating it, right? They can do some good work there. So we're getting 8 more providers involved, and the hope is that my hope is that it will largely be primary care and, which is like straight behavioral health, OBs, primary care, internists, family medicine.
Right. Yeah, it's great to hear about, those settings as a reality in some states and as a possibility for the future too, as CM expands. Dan, we had a question about the Wisconsin program. We heard in your presentation so much about the training that you're offering, to counties and organizations that are interested. The question is, is Wisconsin doing anything else to promote and support the development of CM? And also a funding question within that, is it up to, how does funding work exactly? Is it up to the counties to sort of determine if they'll be funded through SOAR or the block grant?
Yeah. So as far as promotion of contingency management, we provide as many resources as we can. Again, with being a county-led state, we can't force counties or tribal communities to do contingency management. And again, a lot of it's a business decision for their individual organizations. And the funding question is, so for block grant, SOAR dollars, and majority of our contracts, we typically go through either the tribal communities or counties. There are some funding streams within Wisconsin that an individual organization could apply for. And so it just depends upon what the funding is and what the project is. And contingency management could be part of all of those different contracts as long as they are serving the population appropriately, and that contingency management can be done to fidelity.
Great, thank you. Kind of another funding, question that we got in the chat has to do with sort of the climate of funding these days. we understand in today's climate there might be some questions or maybe even pivots away from strategies that promote harm reduction. And so the question is about, are there concerns about, we spoke today about, current funding, SOAR grants have been mentioned, the 1115 waiver, state block grants, but are there any concerns about, future funding? In the space of contingency management. And maybe I'll pass that one to Michelle.
I saw that question in there and didn't really want to touch it in that it's hard to know how to predict about future funding. And I think my only thought, I did have a thought about that. Might leave. Um, I mean, is that thoughtful conversations and education around contingency management and an emphasis on the evidence can really open people's minds. So people have this idea about what CM is and where money is going. And again, if people can have conversations and discussions about it, then oftentimes people can begin to change their minds. So I believe that hearts and minds can be changed about lots of things, including contingency management. I know that because I know a lot of people who have shifted their attitudes. So maybe even we can get people at all levels of government to change their minds about CM to really understand and maybe to also point to literature around the economic benefits of CM overall and how that might be a win for all of us.
That's a great point, Michelle. And I also wanted to mention opioid settlement dollars are also a place, not many states, but we are seeing some states turn to those funding dollars as a way to promote CM in their state. Chris and Tevis next. Partnerships is, key to a lot of what, states can do in CM. Tevis, you mentioned collaborative, relationships that you have with providers in your CM work in New Jersey. So, how would you characterize, partnerships with providers as, kind of key to success in the state? And are there other, partners that you work with that have been also critical to your success?
I think partnering with the providers and making sure that they are that they feel supported, that they're able to share information, what is working for them, what barriers they have, to help each other out whenever there's an issue or a really good suggestion for how to improve the program. We make sure we share that with all the providers. Also working with our Technical Assistance Center, Rutgers University Behavioral Health, to provide the training for the staff and making sure that it's done frequently, because unfortunately in our world, and not just New Jersey, but throughout the United States, staff turnover among providers is something that happens frequently. So if you may train a cohort of workers that are administering CM, but then they move or they're promoted or they've changed jobs or whatever. And so you need to make sure you're frequently keeping your staff trained properly. So also those non-traditional areas of outreach, the shelters, the children and family services, anywhere where proof of a treatment program is required for reunification of a family, for satisfying a parole or probation requirement, anywhere that a client who may need help can be found and directed over to contingency management, and keeping your New Jersey, our statewide hotline is called Reach NJ. So they have a list of all the treatment providers that provide contingency management in the state. So if someone's calling seeking help for substance use disorder, particularly stimulants, they know where they can recommend that they go to get help. So partnering with as many agencies, places that you can, is what's going to build and make your program successful.
Great, thanks. We've got another question in the chat about managed care plans and commercial insurance. And the question is asking, do we know about the adoption of contingency management within managed care and commercial plans, including what that landscape might look like? I don't know if any of you have any thoughts on that you'd like to share. I see some thinking faces. It's a tough one, I know. Yeah, but it's great to see that like Medicaid has been such a vehicle and that we've been able to identify other funding sources, publicly available federal funding sources and state sources. So that's great. But that's an important question that we can think more about at CHCS. Um, all right, I'll put this out there to the group because I know we have a lot of states in the audience today, and we know that states are at various implementation levels of CM. For those states in the audiences that are maybe just getting started um, and wanting to support, advancing CM in their states, where might they start? Um, and Michelle, maybe I'll turn it to you first, and then if others want to chime in, like from your own experience about where your state started, please do.
Yeah, I would point to a couple of my own slides in thinking about who do you want to serve and what behavior do you really want to target, and th those are all the kind of like protocol development questions. I guess that's a little bit narrower than a whole state. Um, but I do so the Pew Charitable Trust, which has supported this webinar, is also supporting some work that we are a part of. Our team at Washington State University and elsewhere, putting together a CM implementation toolkit, which is actually kind of the answer to this question. So that's forthcoming, and we have an incredible expert panel of people all over the country that have a lot of knowledge in this area. So I hate to say like stay tuned for our implementation toolkit, but that's really what it is designed to do, to answer questions about regulations, policies, and funding, as well as, what are some of the first questions that you ask. There are some good resources right here, so that might be another place to start, is to reach out. The other thing is to engage your state's Medicaid director or equivalent. That person is like a real important person in this process. So if you're pursuing the 1115 waiver, then get to know and become friendly with your Medicaid director for your state, because every state is different, very different. So our 1115 waiver is different from Delaware and California and elsewhere.
Sherry?
Yeah, and I want to add that, so yes, I agree. And even if you can't fund everything through it, there's always a good conversation to have with Medicaid about what sort of things can you bill for. For example, we had launched a different program through a pilot, and we were using principal illness navigation and had the MCOs open that code for the pilot for some of our providers. So we'd be thoughtful about ways to fund parts of what you're doing, even if you can't fund the whole thing. And the first thing though that came to mind for me, because we're seeing it even with our DSAM SOAR funded, it will take longer to implement than you think it will. Like it will just take longer. We're seeing over at DSAM, some SOAR grantees, and they're like, God, they've had this grant already for 8 months. Like, why haven't they launched it? I'm like, well, I can tell you why they haven't launched yet. Like, there's a lot to think about that you can't even anticipate until you get started. So, I feel like it requires a lot of patience it requires a lot of patience to sort of stick with it, particularly when you're dealing with the state agency, right? And the feds and the back and forth between the two if you decide you want to do an 1115, which I think provides some protection, right? Now we have to do it. They told us to do it. Now we have to do it. And we're locked in at least for a little while, but it was a lift for sure.
Well, thanks so much for sharing, your perspectives. Everyone on the webinar today, thank you so much. We're just going to bring up the slides just to close things out. We have a slide on ways that you can follow us on chcs.org, if you'd like to, learn more about CM or related topics. And I just want to say a huge thank you on our last slide to all of the presenters today to, give us a window into what CM looks like in your states. I'm seeing lots of applause. I know that's deeply appreciated. Sometimes it's hard to know what's going on in states. So now we got to learn a little bit. Thank you all for your questions and for joining today's webinar. I'll be sharing the slides in the days to come. Have a great rest of your afternoon.